Good afternoon, all. Is the screen visible to all? Am I audible? Please reply in the chat box. Okay. So our today's topic is severe acute malnutrition. It's on page number 155 in the nutrition textbook. Those who do not have the textbook, please don't worry. Just write down the important points or important page numbers, which I may specify here. That's it. You can translate that later when you get the book. So severe acute malnutrition. It is defined by by a very low weight for height, by visible severe wasting, or the presence of nutritional edema. Edema here means swelling. Okay, overall swelling. So this is a kind of malnutrition which is prominently seen in kids. Okay, either in preschoolers or in infants. So their body weight is especially very low as compared to the height which they may be having. Along with that, there is severe muscle wasting. There is a loss of lean mass from the body. Okay, and in some cases they have edema, overall edema, and we call it as kwashiorkor. And when they do not have edema, it is marasmus. Okay, we'll see that later. So how do you identify if a child has severe acute malnutrition or not? Okay, so am I audible to all? If you are having any internet issues from your side, in that case also the voice may break. But in majority, am I audible to all? Yeah, okay. Yeah. So how do you check if a child has severe acute malnutrition or not? So for that, the upper arm of the child, the middle, you have to take the length of the upper arm from elbow to shoulder. Okay, find the midpoint. Okay, midpoint of the upper arm, and you have to take the circumference, like a circumference of the that midpoint of the upper arm. That is how you identify the upper mid arm circumference. Okay, so when you measure that, if the measurement is less than 11.5 centimeter, here it is given 115 mm, you convert that into centimeter, that is much more easier to read on a scale. Okay, so if the measurement, the circumference is less than 11.5 centimeter, we classify the child as he or she is having severe acute malnutrition. Edema means swelling. Okay, it's a medical terminology for swelling, overall swelling. Okay, so accumulation of body fluid is also called as edema. Okay, then you have another statistical point of view to understand that, but for that you have to understand the statistics and all, so don't get into that. Okay, for that you will require calculator, you require much more complicated mathematical formulas and everything. But checking the mid arm circumference is something that anyone and everyone can do. Okay, any auxiliary nurse can do. Okay, any multi-purpose social worker, any social workers, or at home also anyone can check this mid upper arm circumference. So that is the best way to have knowledge about severe acute malnutrition. So you can see here in the picture, this is the kind of tape which is used. Okay, to check the upper arm circumference. Here the child is suffering from severe acute malnutrition. That is why you see the upper arm circumference, it is exactly 11. Okay, exactly 11. It is less than 11.5, so it is 11 centimeters. So you classify the child as he or she is having severe acute malnutrition. Okay, so what is severe acute malnutrition? The weight is too low, very low weight as compared to the height. Every height has a comparatively range of weight which has to be maintained. Okay, so the child's weight will be severely low as compared to the height. Along with that, there will be excessive muscle wasting, loss of muscle mass, and in some cases there will be overall accumulation of body fluid and swelling called as edema. Okay. Now, classification of severe acute malnutrition, there are two ways. First is the clinical classification. So severe wasting, which you can see here in the picture on the extreme right, okay, the child here, you can see here, ideally when you see this child, you can see the ribs, okay, bones are, the structure of the bones are very much visible. You can't see any muscle mass whatsoever, okay, very loose skin. Like, okay, here even in the picture they have mentioned hair loss. There will be no hair on the child. The overall appearance of the skin will be dry and wrinkled, okay, and there is severe muscle wasting. You can see the entire skeletal structure of the child through him. Okay, so this is severe wasting. We call it as marasmus in medical terminology. Then you have nutritional edema. Come on this right side picture. Okay, the child has a distended abdomen. Okay, this abdomen is filled with fluid. Okay, scaly skin, distended abdomen. Okay, swollen ankles and pitting edema. Again, pitting edema means bilateral pitting edema is given in the textbook. Bilateral pitting edema means not just on one side, on both the sides of the body, both the legs, both the hands, etc. When it is swollen in such a way that when you press, there is a pit formed. Okay, and when you press the swelling and you remove your finger, you can see how deeply you have pressed. Okay, a pit is formed. That is called pitting edema. So bilateral pitting edema is seen in kwashiorkor. Okay, so this is kwashiorkor, marasmus, severe muscle wasting and nutritional edema. This is the clinical classification. Then you have medical complications. Okay, in some case you have uncomplicated severe acute malnutrition. Okay, from the name itself you can understand what it could it mean. The child is obviously malnourished, but he or she may not be having severe symptoms for malnourishment. Okay, so even the child may not require hospital admission. Okay, in an outpatient basis you can treat these cases which are uncomplicated severe acute malnutrition. Okay, these kind of cases can be treated well in the outpatient settings. At the home, domiciliary care can be given. Okay, so you don't see any severe metabolic disorders or metabolic dysfunction in the kids who suffer from uncomplicated severe acute malnutrition. Then you have complicated malnutrition. Definitely you have to give hospital admission for these children. Okay, for weeks and weeks that treatment will be going on, diet risk treatment as well as other infectious management, etc. Okay, various forms of management will be given to the kids who come under complicated severe acute malnutrition. Okay, all the management we will discuss later. So you will see the symptoms such as metabolic disturbance. They're not able to metabolize carbohydrates, proteins, all the macronutrients cannot be metabolized properly. Okay, they have severe edema like this. Okay, a hypothermia, their body temperature will be too low. Okay, because when a child is suffering from malnutrition, their cardiovascular system is also involved. Their heart is not able to give much of cardiac output. So what will happen is the overall circulation, blood circulation in the body will be very low. When the body has a very low blood circulation, automatically the extremities means your hands, limbs, okay, it will be very cold because of low blood circulation. Okay, so naturally the child may suffer from hypothermia, vomiting, severe dehydration, okay, anemia, lack of appetite. They will not be hungry even if they are in such a malnourished stage. They do not have an appetite for anything. Okay, so in these cases compulsorily inpatient treatment has to be given. Okay, so these are the classification for severe acute malnutrition. The clinical features. Okay, how distinctively is marasmus different from kwashiorkor? Okay, so one thing you have to remember here, marasmus is commonly seen in children who are less than 1 year old. Okay, from 6 months to 18 months. 1.5 year old. Okay, from 6 months, the child who is 6 months old to 1.5 year old, but they are at the highest risk of catching marasmus. Okay, that is the when a malnourishment happens in a child who's in this given age from 6 months to 18 months. Usually it is marasmus. Okay, and when a child is much more developed, about 3 to 5 years, in that cases they acquire kwashiorkor. Okay, so marasmus, why does it happen? It is due to low calorie intake. There is severe growth retardation, severe reduction in the body weight, because you can see the child is losing all the muscle mass here. Okay, shrunken abdomen. Their abdomen is completely gone inside, just the opposite of kwashiorkor. In kwashiorkor, distended abdomen. Abdomen is filled with fluid. Okay, so here we have shrunken abdomen, and subcutaneous fat is not at all preserved because fat is completely lost. Prominent ribs, you can see here, the child's ribs is very much prominent, not just the ribs, any bony prominence that the child may be having in the body, everything is very prominent. The joints, you can see the elbows, knees, okay, all the bony prominence, okay, that are very much prominent. Voracious feeder, the child will be hungry all the times, but whatever the child will be having is not metabolized enough in the body. Okay, there is no fatty liver. Fatty liver is something which we will say in kwashiorkor. Okay, edema is not present. Old man like face, because it is, the skin is very dry and wrinkly. Okay, there is no hair changes noted, but there is loss of hair, dry and wrinkled skin. Alert but irritable. The child is alert. The child knows what is happening around. The child knows what is happening around, but the child is very irritable. Apathy. Okay. And these kids require adequate amount of protein, fat, and carbohydrates as a replacement nutrition therapy to get back to catch up with the growth and development. Okay. Now here in kwashiorkor, usually in preschool children who are 1 to 5 years of age. 1 minute. So in kwashiorkor, it is commonly seen in preschool kids from 1 to 5 years of age due to low protein intake. You can see here what is the difference. Here, marasmus is due to low calorie intake. Here it is due to low protein intake. Mild growth retardation, okay, because the child has grown enough, okay, because up till the age of 5, some kind of growth in height is there, but along with that, other symptoms have caught up. Mild reduction in body weight, protruding abdomen and subcutaneous fat is preserved. Ribs are not very prominent. Poor appetite. Here, that is the difference. The marasmus child, the child who's having marasmus is hungry all the time. But here in kwashiorkor, the child has no appetite. Okay, enlarged fatty liver. Marasmus, there is no fatty liver, because fatty liver means fat cells are deposited on the liver tissue. Okay, that is what we call as a fatty liver. When the fat lipids are not properly metabolized, okay, not digested, okay, free flowing fats in your blood, those come and accumulate in your liver and convert that into a fatty liver. Usually fatty liver is a very common case in case of alcoholism and all. Okay, edema is present. You can see here the completely the body is swollen. Moon face, the child's face is completely round because of the edema. Sparse hair is very thin, and the color of the hair also changes. The melanin from the hair reduces drastically. Flaky paint like skin, lethargic, the child is very tired all the time. Requires adequate amount of protein, because kwashiorkor has took place. It is severe acute malnutrition from nutrition book. So requires protein intake for replenishing the deficiency in protein. So these are the main clinical features you have to understand how kwashiorkor is different from Marasmus. Then we have another case which is called marasmic kwashiorkor. This has a list of symptoms, signs and symptoms from both these disorders. Okay, so the in the most common cases, you can see, if you just divide the child's body, the upper body, you can see it is marasmic, because you can see the loss of muscle mass in the upper body. But when you come to the lower body, it has swelling. Okay, it is edematous. The lower body is edematous and the upper body has severe muscle wasting senior. Okay, so the child having marasmic kwashiorkor is a severely malnourished child with features of both marasmus as well as kwashiorkor. Okay, for example, edema on the feet and legs and also hands is from kwashiorkor. Okay, also there is pale skin and the hair is also pale. The child is unhappy. Okay, there are also signs of marasmus, like wasting of the muscles in the upper arm. You can see here in the image, upper arm, even in the chest, upper chest region. Okay, you can see the ribs. So this is the, it's a mixture of both these cases, and we call it as marasmic kwashiorkor. Another different types of malnourishment which we commonly see in developing countries are stunted growth. Like here the height will not increase. Okay, because of a because the child has adapted itself, the child's body has adapted itself to low protein diet, and because of that there is stunting, severe stunting seen. Okay, stunting means height will be affected. And this is a normal baby of the same age, you can compare them. Okay, and then this is a wasted baby, in which the muscle, you can see how normal baby should look like, how plump the baby should be, and how a child with wasted muscle mass looks like. Okay, all the skeletal features can be visible from outside. So these are the different types of childhood malnutrition. So normal child, in wasted child, height is not much affected, but severe loss in muscle mass and loss in weight. Stunted child, there may be adequate weight, but height has not reached the normal height for the age. And then underweight, low weight for age. This image is given in the first page of this chapter, that is on page number 155. The same image is given. You can compare that. Now, changes in the organs and system because of this malnourishment. For digestive organs, the pancreas, the mucosa are atrophied. Atrophied means they have reduced in size. Okay, there is a normal size for the cells in pancreas, the cells in the mucosal lining. Okay, when these cells undergo atrophy, what happens is they're reduced drastically in size. Okay, along with that, their physiological function will also be affected. That is mucosal atrophy, because of that, the digestive organs secrete enzymes, they secrete digestive juices. Okay, it will not be secreted adequately. In liver, what happens is fat accumulates. When if it is a case of kwashiorkor, fat accumulates. Small droplets of fat will accumulate in the liver cell, and it will lead to fatty liver. In cardiovascular system, even the heart muscles undergo atrophy. The heart muscles will, if it undergoes atrophy, it becomes smaller in size. The cardiac output will reduce. If the cardiac output reduces, the cardiac output means the amount of blood the heart is able to pump. Okay, if that reduces, automatically the entire blood circulation will come down. Okay, and the child will go in the stage of hypothermia, because blood is something that keeps us warm, and when the blood comes down, the circulation comes down, automatically the body goes into the stage of hypothermia, because drastic reduction in body temperature. Then in kidneys, in some cases, proteins should not be excreted through the urine. Okay, but when a child has malnourishment, it is seen that mild albuminuria, protein, traces of protein in urine is found. Okay, that is how it affects the kidneys. Immunological system, you can always say malnourishment leads to impaired immunity. Okay, a lot of lymphocytes, T blood cells, and other enzymes which helps us in our immunity, they require protein, okay, for their sustenance. If it is not found in case of malnourishment, automatically the immunity will be affected. Then we have the mental development of the child. There is a production in glial cells. Glial cells are kind of neurons found in the brain and the spinal cord. Okay, DNA, RNA, synthesizing proteins. Okay, total lipid, cholesterol. When these things come down, automatically the mental development of the child is affected. And hormones, you can refer table 8.2 on page number 160. There are a list of hormones and how malnourishment affects these, the secretion of these hormones is listed down. Insulin, all the kind of insulin completely drops. The secretion of insulin drops. Growth hormone, needless to say, it drops. Okay. Epinephrine, glucocorticoids, you can see how different types of hormones is affected because of malnourishment. Some will, in some the rate of production is increased, in some hormones the rate of production is decreased. So you can just read through table 8.2, no need to by heart. Okay, just read through and understand. Okay, how is protein energy malnutrition and severe acute malnutrition affecting the secretion of hormones. Then we have biochemical and metabolic changes. So in protein metabolism, it is drastically affected. The plasma albumin concentration is low. Plasma albumin means the protein, the essential amino acids and proteins which should be found in your blood plasma. Okay, that comes low. And mostly what happens is this blood plasma, which has to be the protein which should be in the blood, is excreted out of the kidney through urine. It will be passed out. That is abnormal. Okay. Lipid metabolism, free floating fat cells, okay, as told earlier, will go to the liver and it will stick to the liver cells and accumulate and cause fatty liver. Carbohydrate, usually there is not much metabolic changes found in the breakdown of carbohydrate. If enough carbohydrate is given to the child's body is able to tolerate it. Okay, so glucose tolerance is also normal. Okay, so in case of carbohydrate, there is not much of abnormal biochemical or metabolic changes seen. But when it comes to protein and lipid, a lot of abnormalities are seen. Electrolyte and water, plasma potassium level is below normal. Okay, sodium level is below normal. Magnesium level is below normal. Okay, these all electrolytes are very, very important for different kind of functions in the body. For example, potassium is required so that potassium can be given in exchange of absorption of sodium. Okay, so for various biochemical changes that takes place in the body, the electrolyte balance should be maintained. So if it is deficient, if the body is deficient in certain electrolytes, automatically these functions will all be impaired. Then vitamin A. So we have it has been seen that in case of malnourishment, the metabolism of vitamin A is interfered by there is a reduced absorption of vitamin A in the intestine. Also, when the beta carotene is the form of vitamin A in which liver preserves vitamin A. Okay, liver will not preserve vitamin A in the exact form of vitamin A. It preserves it in the form of beta carotene and all. So converting the beta carotene into vitamin A and then utilizing from the body, okay, everything is impaired. Now coming to the treatment part, how you will treat these kids. Okay, so first is nutritional requirement. So provide adequate levels of protein and energy will so it has to be given. Okay, and always remember when you're starting a nutritional treatment for kids who are malnourished, in the first few days itself, excessive amount of nutrition should not be given, because in the previous class we have discussed about the refeeding syndrome. These children will also go into that refeeding stage. Okay, so to prevent that, gradually over a period of time, additional nutrients are added into their feeds, and their growth is able to catch up with their normal age. Okay. So under nutritional requirement, the energy, these things you can underline on page number 164. Okay, energy, what is the range of energy, how much energy should be given for a child under various age groups, it is given. So a child should be given around 150 to 200 kilocalorie per kg of their existing body weight. If the child is weighing just 5 or 6 kg, okay, you have to multiply 150 to 200 kilocalories into that body weight which the child has, and that amount of uh, complete nutrition should be given throughout the day, not per meal, throughout the day. Okay, so and if the child is less than 2 years of age, 200 kilocalories per kg body weight should be given throughout the day. For older children, 150 to 175 kilocalories per kg body weight should be given. Okay, this is not per meal plan, it is per day's plan. This entire calories which you will get after doing the calculation, that has to be divided into frequent small meals. Okay, 5 to 6 meals throughout the day, it has to be divided, and it has to be provided to the child. For protein, 5 grams of protein per kg body weight of the child, that should be the formula. Fats, around 40% of the total calories can come from fats, and it can be tolerated by the children. 40% of the calories coming from fat can be tolerated by the children who are having malnourishment. And it is better to use saturated fats such as buttermilk, coconut milk, ghee, okay, milk and all. So such kind of saturated fats should be used instead of unsaturated fat. Avoid using refined oil for dietary requirement of malnourished kids. Then in electrolytes, 2.4 grams of potassium chloride, 0.5 grams of magnesium chloride. Okay, usually these are the things which you can't calculate and give. It should be naturally present in the fruits, nuts and vegetables which is provided. And also specifically when you're treating a child with malnourishment, you have supplementary diets also, and through that this micronutrient requirement will be met. So about electrolytes and minerals, the dietitian doesn't have to worry much, because through supplementary feeding these things can be met. Vitamins, vitamin A deficiency should be the first thing that has to be addressed. So in the initial first or second day of admission, when the child is admitted in the hospital because of complicated severe acute malnourishment, within the first day itself, 50,000 international unit of vitamin A will be given, either orally or the injection will be given, okay, in a fat soluble form. And after that, after giving this 50,000 international units in a single dose, slowly every day 5,000 units will be given up till the child is getting speedy recovery. Till that time, this has to be maintained. Now the other management that which is the wholesome of the management which is done in the hospital. So there is an initial treatment. Okay, all the life-threatening problems when the child is admitted with severe acute malnourishment in the hospital. Okay, there are n number of life-threatening problems that the child may have, like hypoglycemia, hypothermia. Okay, it has to be the child will be in a critical stage at the time of admission. So all the life-threatening problems are identified and treatment is given. So this is from a medical point of view. The doctors and the nurses will take care of this part in the pediatric intensive care unit. In the PICU, these things will be taken care. Later, they will be moved into the ward. Okay, after initial treatment. For rehabilitation, second is the rehabilitation. This will be done in the regular general wards and all. Okay, so intensive feeding is given, calculated feeding within 2 hours. This has to be given. this much ml has to be given within 2 hours, this much ml has to be given within 4 hours. Okay, that kind of extensive and intensive feeding that will be taking place in the rehabilitative stage. What is given, we will discuss that later. Okay, but you have to divide the entire management into these 3 sections. Then after rehabilitation, when the child is completely recovered from malnourishment, still there is a lot of catching up in state of mental health and other forms of growth. Okay, this catching up has to be done. The entire catch up of the growth and development will not be done in the hospital itself. So that is why we require follow up. After rehabilitation, the child will be discharged. Okay, even after discharged, planned follow up has to be given. Within 1 week, you have to come with your child. Okay, the mother, the parents and the child both have to come back within a week. Okay, after the first follow-up visit, the second schedule will be given next when they have to visit. Okay, so that is a planned follow-up that will be given, because parenting skill has to be monitored. The child's recovery after discharge has to be monitored. Okay, so this is how you divide the entire clinical management: initial treatment, critical care, and the life-threatening treatments and ailments will be elevated here in the initial treatment. Rehabilitation will be done in the ward. The focus is on the feeding. Okay, and follow up all the domiciliary care, health education, etc. So this is the table. It is given on page number 165, table 8.4. Okay, it is the same thing. So what all activity, initial treatment, rehabilitation, and follow-up. So all the which condition has to be treated in which part, when the treatment has to start. Okay, you have to follow this form for that. If you are a practicing doctor or nurse, you can follow this. Those who are practicing in a freelance area, or those who want to practice in a consulting field, you do not have to follow this thing, because this is exclusively for medical practice only. For in pediatric units and pediatric care hospitals, they have to follow this. Okay, so hypoglycemia, hypothermia, dehydration. Okay, these are the critical critical care things which has to be taken care within the first 2 days of admission. Okay, then slowly you can correct the electrolyte imbalance. Okay, it may take weeks, 2 to 4 weeks it may take. And along with that, with the first day itself, antibiotics should be given if the child has infection. Okay, if the child is suffering from any infection, start the antibiotics. Do not prolong the antibiotics for more than 3 weeks. Ideally, within maximum 3 weeks should be the antibiotic prophylaxis, not more than that. Otherwise, the child may develop some antibiotic resistance, and that is another issue. So, yeah. And micronutrient deficiency, slowly you can start either without iron. That is an important thing. When you are giving nutritional feeding in the initial few days of treatment, iron should not be given. Iron should be avoided, because there are iron may give some toxicity to the child. Also, it will inhibit the absorption of certain nutrients. So iron is very notorious for that. So that is why for the first few days, ideally for the first week, nothing which consists iron is given to the child. Okay, after that, during the rehabilitation stage, when the child has been moved to the wards and focused feeding is given, at that time you can introduce iron in the feed. Up till that time, iron should not be given, because it can lead to certain toxicity. So yeah, this is the table which you have to follow for treatment plan for malnourishment. Principles of management on page number 166. In case of dehydration, if severe dehydration is there, you can only provide IV therapy, okay, intravenous fluid therapy, putting the child on dextrose, TNS, and all. Okay, so that is the clinical side. If the child is not having severe dehydration, it is mild to moderate, these can be treated at home also. Okay, always remember you have ORS for that. Okay, ORS should be given in 1 liter of water. Okay, whatever is the whatever the formula has stated in the ORS packet, all the instructions and what to do is mentioned. According to that, you can follow that to give to elevate the dehydration. Okay, otherwise, if ORS is not available, if you are working in a very rural area where you do not have access to frequent access to ORS and all, this is the thing which we practice in community medicine also. So you have to educate the parents to boil 1 liter of water. Okay, completely boil 1 liter of water and then cool it down. Bring it down to room temperature. You have to wait till the water cools down to room temperature. After that, a fistful of sugar. Okay, whatever be the size of your fist be, what okay, a fistful of sugar. How much sugar you can hold in one fist, that has to be uh, diluted in that boiled and cooled down 1 liter water. After that, a pinch of salt. A pinch of salt means between your index and your thumb. Okay, between the index and your thumb, how much amount of salt you can hold. Okay, that amount of salt should be added into this 1 liter of boiled and cooled down water. Mix it well, completely dilute it. Okay, and then throughout the day, this has to be given to the child. This 1 liter of boiled and cooled down water with a fistful of sugar diluted and a pinch of salt, it has to be given to the child. That is how you make ORS at home when you do not have access to the pre-formulated ORS sachets which is available. Okay, so that kind of health education you should be able to give. In dire circumstances, we do not know, so that is how we prepare homemade ORS. Okay, then in case of infections, diarrhea, measles are the common immediate cause of death if a child is having malnourishment. Along with that, if the child gets diarrhea and measles, okay, that is a very common cause that will lead to the death of the child. So that has to be elevated. And infections like giardiasis, ascariasis, these are worm infestations. Okay, like infestations, that has to be taken care of by giving anti-helminthics and all. Okay, hypoglycemia, um, by giving some milk based feed. Okay, milk based feed, but the milk should be very less in protein. Okay, because in the initial few days of giving treatment, as soon as the child is admitted, in the first few days, you do not give protein rich diet to the child, because the child may go into refeeding syndrome. That is why you hold back a bit on protein. You do give protein, but in very few quantities. Slowly, gradually you have to increase the intake of protein. Okay, the first few days, a limited protein intake should be measured. So to treat hypoglycemia, either give glucose water or by giving low protein milk. Okay, that is enough. Hypothermia, make sure the best thing is ask the mother to sleep with the child. Okay, it's always preferred that the mother sleeps with the child to elevate hypothermia. Give them blankets. Do not put these children in AC room. Okay, give them blanket to control the temperature. Then in case of congestive heart failure, that's the very critical stage. In that case, you have to start diuretics. Digitalis, that these congestive heart failure will be taken care by the intensivist and all who are in the PICU. Okay, the drugs available, the crash cart available, based on that everything will be taken care of. So congestive heart failure is the stage, it's the most critical stage when it comes to the management of malnourishment. So that is the medical aspect of it. As nutritionist and dietitian, you do not have to indulge in the management of congestive heart failure. That is for the medical practitioners. Now coming to formula diets. Okay, so this is the main focus in initial treatment as well as in rehabilitative treatment, the first few parts. So formula diets, you have two types of formula diets. F75 and F100. So what is 75 and 100? Okay, so 100 ml of F75 will give 75 kilocalories, okay, of energy. Okay, and 100 ml of F100 will give 100 kilocalories. Okay, so that is the main difference. So in the initial few days, the first few days, only F75 is given. Okay, and when the child starts getting hungry, okay, at that time F100 is given. Okay, so F75, always remember, questions may come from this. F75 means it's in the second paragraph on page number 165. F75 is the kind of formula. Okay, in this formula, the difference is the amount of kilocalories, KCAL, okay, kilocalories, which the child is getting. So when you are giving F75, 75 kilocalorie the child will get per 100 ml. Okay, 100 ml of F75 will give 75 kilocalories. From the name itself, it is understandable. Okay, 100 ml of F100 will give 100 kilocalories. Okay, it is given in the textbook. Read that paragraph, you will understand. Okay, so these are the things that these two formulas are made up of. Okay, easily available items. Okay, in the locally available, easily available, inexpensive items are used for making F75 and F100. Okay, so when are these things given? So in the initial phase, okay, in the initial phase of treatment, you give F75. That is the first few days when the child is admitted, F75 is given. Okay, later in the rehabilitation phase, remember the initial phase, rehabilitation phase, and the follow-up phase. Okay, in the rehabilitation phase, F100 is given. Okay, so we will not bombard the child with a lot of nutrient, because we do not want to get the child to go into a refeeding syndrome stage. So that is why slowly and gradually we increase all the nutritional value of these feeds to 100 F100. Okay, so you can see the difference between the amount, the constituents of each of these feeds. Okay, so dried skim milk, that is the milk powder. Okay, milk powder of skimmed milk, because we have to really focus on low protein and low fat diet here. Okay, in the initial few days you can't give high protein and high fat diet to the child. Okay, so dried skim milk 25 gram, sugar 70 gram, cereal flour, any cereal flour that is locally available and easily available. Okay, so 35 gram, vegetable oil, ideally it is gingerly oil used, so vegetable oil, and if possible unrefined is preferred. Okay, so 27 gram, mineral mix, vitamin mix, that is already it's a completely different sachet already available. Okay, so mineral mix and vitamin mix to 20 ml, 140 mg, and water to make this. Okay, in 1 liter of water, you have to measure all these things and mix it properly. Okay, and you can see the difference here. In F100, cereal flour is not used, because in rehabilitative phase, what is happening is you start with home cooked food. Okay, you start with home cooked food in rehabilitative phase. On top of that, you give them F100. So in home cooked food, especially in Indian diet, home cooked food, you have lots of cereals and pulses. So that is why you do not put cereal flour here. Okay, that is a difference. Okay, cereal flour is not there in F100. It is only present in F75, because in the initial stages of treatment, outside food is not given. The child is completely dependent on this diet. Okay, in rehabilitative phase, you make a combination of home cooked food or the food that is given by the hospital. Okay, that food along with that F100 is given. So that is why you avoid cereal from this stage. Okay, now feeding on admission, when the child is admitted, to avoid overloading the child's intestine, liver and kidneys, Okay, frequently frequent feeds with small amount of feed is given. Okay, and the children who are unwilling to eat, especially it happens in the case of kwashiorkor. In kwashiorkor, the child will not have the appetite. In marasmus, the child is willing to eat because the child is always hungry. In kwashiorkor, the child is not hungry. Okay, he or she may fight, okay, to eat. In that case, forcefully you may have to put the child into NG tube feeding. Okay, I guess you remember NG tube feeding, the tube feedings which we have discussed in previous class. Okay, so in that case, you have to put the child in NG tube feeding and you have to give these feeds through NG tube. So that is how you take care of feeding on admission, and diet is given in every 2 hours, 3 hours, or 4 hours as how it is prescribed by the consulting doctor. According to that, feeding is given. Then feeding after improved appetite. After 1 week, slowly the child's appetite will improve, because when the appetite is improving, remember that any underlying infection which the child may have had earlier, that is taken care of. Because when the infections are taken care of, when the digestive and metabolic state has come back to normal, that is the time when you understand the child is getting hungry, okay, and the child is willing to eat on its own. Okay, so having an improved appetite is a positive sign that underlying infections are taken care of and the body's basic metabolism is coming back to normal. Okay, so when once the child is in this stage with improved diet, when the child becomes essentially hungry, okay, this occurs after 2 to 4 days of initial phase. The child has to be quickly transferred into F100 diet. Okay, and this transition should be very gradual to avoid the risk of any heart failure or any other systemic failure. Okay, suddenly do not allow the child to consume large amount of feed. Slowly, the feed has to be increased. For example, if you are giving 50 ml in the morning, in the afternoon give 60 ml, in the snack time give 70 ml. Okay, like that, slowly with each meal you can increase 10 ml till when the child says he or she doesn't want anything more. Okay, till that you have to slowly increase the feed by 10 mls. Then in case of deficiency, especially vitamin A deficiency has to be addressed. The day when the child is admitted in the hospital, the same day 50,000 international unit of vitamin A is given either orally or through the IM injection. And slowly the day after that, second day onwards, 5,000 international units of vitamin A is administered till the child becomes normal. Okay, and all the other food which is given, like supplementary food, everything which is given, usually it is fortified with a various list of essential minerals and this thing. Vitamin A, will discuss that later. One topic is coming up, the second topic, nutrition and infection. In that you will understand why vitamin A is that necessary. Okay, because one thing remember, when the child is in a severe acute deficient state of vitamin A, the child may become blind. Okay, because I guess you may know the deficiency of vitamin A, it leads to night blindness and everything. Okay, so that is why it is so important. We want to prevent blindness also among children. So that is one of the reason. Other reasons are also there on the importance of vitamin A. So deficiencies has to be taken care of after the child has got an improved appetite, when the child is hungry and all. After that, slowly you can take care of the other micro deficiencies which the child may be having. Okay, so giving fortified food, okay, a food which is fortified with iron, minerals, and all such things, it can be started after the appetite has been improved. Then nutritional rehabilitation, the table is given in a picture is given, figure 8 on page number 169. Okay, it is stated at the time of hospitalization, the day when the child is getting admitted, lot of blood investigations etc will be done by the laboratory. Okay, then in the initial stage, all the medical emergency, the child may be in a stage of hypothermia, the child may be in severe dehydration. Okay, a child may be in the state of hypoglycemia. These are like life threatening conditions, those has to be elevated. Okay, then slowly in rehabilitation stage, they will slowly start to gain weight because they're hungry, they eat more, they slowly gain an adequate weight according to their height. Then what is your goal? The child is of a certain age. In that age group, the child may be having a range of normal weight. Now the doctors and the nurses goal should be to the height that given to the height the child has got the weight. Okay, according to the height, what is a normal weight the child should have, we have reached that stage. Now what next? According to the age, what should be the child's weight, we have to go there. Okay, so that is the final stage. So once you have brought the child to an appropriate weight according to that age, then from there on normal growth and development will take care. When the child is under 24 months, that is under 2 years of age, okay, F100 diet is given every 4 hours, even at night. Okay, even at night, you may have to wake up the child and give the feed. The exact amount of what ml should be given is also prescribed by the physician. Okay, even at night, every 4 hours, day or night, it doesn't matter. Every 4 hours, the prescribed ml of feed has to be given. And slowly again, you can slowly increase the feed by 10 ml here also. Then follow up, no, not much to say about that. All the health education, parental, what parental skills the family should have to take care of the child who was affected by malnourishment, and planned discharge, etc. has to be given. Okay, that is the follow-up care. Diet during convalescence. Convalescence is the stage when after discharge, when the child goes home. Okay, and when the follow-up is going on. Okay, that is a phase of convalescence. Okay, when the child has kind of coming back to his or her normal health. That is the convalescence stage. So in convalescence stage, what kind of diet the child should be having? Okay, increase the quantity of the food. Like idlis, whatever they're having already, their staple food. Okay, whatever the child was having before admission, increase the quantity, increase the number of meals to satisfy the calorie. Earlier the child was having only 3 meals per day, break down those meals into 5 meals per day. Okay, just by adding a teaspoon of ghee or oil, 1 to 2 teaspoon of ghee or oil on the food, that is enough to increase the calories without increasing the quantity of the food. Okay, regular consumption of sugar and banana can increase the calories. Cereals and pulses can be given in the ratio of 5:1. 5 part of cereal, 4 part of cereal and 1 part of pulse. That should be the ratio. If the family can afford milk, egg, etc., that can be included. And whatever diet you prepare for the child, it should be locally available, inexpensive, and it should be easily digestible. Then that's the ready to use food, therapeutic food. Okay. You should know the abbreviation for this. Okay, and what is the consistency of it? It is very important. The main thing which you have to remember here is this therapeutic food is not the replacement of regular food. It is not the replacement. Regular food should be given. Along with that, this is the addition. Okay, regular food plus this therapeutic food, that will make the complete diet. This is necessarily not the replacement of food. Okay, so the main components of this food is roasted and ground peanut, sugar, skimmed milk powder. Okay, and vegetable fat, ideally it is gingerly oil used, and sometimes this is fortified with vitamins and minerals. Okay, so those deficiencies can be taken care of. So the ingredients you can see here, the same is given in the textbook also. So ground roasted peanut powder, 30 grams, milk powder, skimmed milk powder, 28 grams, sugar, 25 grams. So that is the ratio which is given in the textbook, that you have to remember. Okay, and 15 gram of gingerly oil is used to make this mixture, and it is ready to eat. No need to mix it with water or milk or anything. Okay, you can directly cut the package and directly give it to the child. Okay, so it is a ready to eat food that has been, it was under research for around 9 decades kind of thing. It is given in the book. Okay, and the main thing here, how it is so good as compared to other supplementary diet is it has a lot of advantages. For example, when you talk about peanut in developed countries and all, like USA, European countries, you may find lots of kids have peanut allergy, but it is seen that in developing countries like India, South Africa, and all, peanut allergies are very rare. It is not that common. So most of the kids can have this. Okay. On top of that, when it is in ready to eat form, it has no risk of contamination because you do not use liquid milk. You are using dried milk. So there is high, very less chance of infection and contamination. And it is easier to use, and you can take it anywhere. It is easy to use. It is ready to use. Okay, so you nobody has to, the caretaker doesn't have to fuss about making these things. Okay, so there is no risk of nosocomial infection, healthcare associated infection, when you are supplementing the child with this. If the child is allergic to peanuts, it can be peanuts can be replaced with other nuts. Okay, you can find in the Google what are the other nuts like walnut and all. The kind of nuts the child is not allergic to, but it is rich in protein and it is a good source of fat. That nut can be replaced. Okay, but when we are talking about developing countries like ours, peanut allergy among children are very rare. Okay, it is not seen much. The rate is much different in developed countries. Okay, so this is an important topic. So please mark that what it is made up of and how it is advantageous as compared to other kind of feeds. In prevention, health promotion has to be taken care, like prevention of malnourishment, health promotion, like in every primary health centers, nutritional supplement should be given free of cost. Wherever possible, in all the maternity hospital, in all the hospital, promotion of breastfeeding, 6 months of exclusive breastfeeding has to be promoted. Low cost weaning food has to be used, seasonally available foods, locally available food, staple food has to be used for weaning, and improved family diet, nutritional education among the parents, and family planning and spacing of the birth, at least 3 years of spacing between two children. Okay, so in specific protection, immunization. Okay, all the child should be immunized, given by the universal immunization schedule given. Okay, all the food the child which may be having, it should be rich in protein and energy rich food fortification wherever it is necessary, it should be added in the diet. Early diagnosis and treatment, surveillance should be done by the local government for all the kids who are at the risk of malnourishment. Regular periodic surveillance should be done by the local government agencies. Early diagnosis and treatment of infections like diarrhea, parasite infections, etc. And at the school also, a nutritional supplement as well as anti-helminthic supplements can be given for the preschoolers from the school itself. Okay. Then you have ICDS, Integrated Child Development Services. Integrated Child Development Services means all the different services targeted for the health and well-being of the children. It comes together at one point, and from that one point itself, all the areas like infection, nutrition, growth and development, everything will be met at one stage, one key area itself. Okay, so that is Integrated Child Development Services. So immunization, that comes under the child health. Supplementary nutrition comes under the child health. Growth and development, monitoring growth and development. If you have visited a maternity hospital, like after the birth, there will be a pamphlet given to the child, to the parents. Okay, the pamphlet may consist of the weight of the child, height of the child, which they have to regularly monitor, bring it back every 6 months, like that. Okay, so that is a growth monitoring pamphlet. The nutritional education, mothers should be educated on the importance of nutrition, importance of breastfeeding, etc. How to introduce weaning food, how to introduce different nutritional supplement. These kind of education should be given to expecting mothers as well as new mothers. Any doubt in this topic? Recording is for the institution's purpose. For privacy policy, recordings cannot be shared with the students. That is why we have repeated classes. If at all you miss any class or you want to revise the chapter again, you can attend the repeated classes. Once by March, mid-March, repeated classes will start for nutrition. So recordings cannot be given, but important topics and everything will be shared before exam. Protein deficiency causes kwashiorkor. Extreme protein deficiency causes kwashiorkor. Protein, energy, and carbohydrates and fat, all of these things deficiency will cause marasmus. If hypoglycemia is severe, then the child will be put under the dextrose, 30% dextrose solution in IV therapy. Okay. But if the hypoglycemia is not severe, just by giving milk feed or glucose in water, that is sufficient. But if it is severe, obviously you have to put the child under the intravenous fluids and all. No, elephantiasis is not under severe. Elephantiasis is a vector-borne disease. Okay, filariasis, elephantiasis. That is it's a vector-borne disease. It's another kind of infection. So severe acute malnutrition is just by the name, because of the deficiency in nutrients. The child is severely malnourished. That's it. Elephantiasis is no, it is not genetic. It is a lot of social factors are there behind this, like developing countries, lack of resources, poverty. Lot of social factors may lead to severe acute malnutrition, but it is not genetic. I'll start with the next topic, nutritional infection. After that, if anyone wants to check the slides again, please remind me then. Okay, otherwise we may be wasting the time now by showing the slides. Protein, 5 grams of protein per kg of body weight. So yeah, nutrition and infection, it's on page number 461. 461, nutrition and infection, those who have the textbook. So malnutrition and infection, they are interrelated. Malnutrition will lead to infection. Prolonged chronic infection can also lead to malnourishment. Okay, so this is a chart which explains that. So when a child is suffering from infection for a very long time, impaired barrier protection will be there. Barrier protection means, for example, the mucosal lining which you have in your gastrointestinal tract, from your mouth till the small intestine and everything, a mucosal lining is there. That is a kind of barrier protection. Your skin is a barrier protection. Okay, your nostrils. Okay, the hair in your nostrils. Those are the examples of barrier protection. Okay, so impaired barrier protection, impaired immune function, your immunity is impaired. Okay, this will lead to either malnutrition, nutrition. Okay, and another thing is when the diet is very less in good nutrient, decreased nutritional intake. If the child is suffering from some GI condition which leads to malabsorption, there is no adequate absorption of nutrients, increased catabolism. When both are interrelated. Prolonged malnutrition will lead to various kind of infection because immunity is impaired. Also, prolonged infection. Okay, prolonged infection will also lead to malnourishment. Okay, both. If any of these two goes on for a very long time, it will lead to the other. Okay. Increased catabolism, when whatever the child is having, it is excessively broken down and it is not utilized, it is just broken down and excreted from the body. Okay, so that is increased catabolism. These things also will lead to infection and malnutrition. Okay, so what happens is in case of malnutrition, there are certain vitamins and minerals what are very essential to keep your immunity intact. If your immunity is not intact, you will acquire infection. That is how malnutrition will lead to infection. What happens in case of prolonged infection? Okay, slowly and slowly, the child's appetite will come down. Not just that, the metabolism, the rate of absorption, okay, everything will come down. So automatically, even if the child is having enough food, okay, but if it is not metabolized properly, it is not absorbed properly in the body, it will lead to malnutrition. Okay, that is how these two things are interrelated. Then coming to the basics of immunity. Okay, your immunity is divided into two sections: innate immunity and adaptive immunity. Okay, innate immunity is something which you are born with. Okay, it is something which you are born with. Remember that innate is already there in your body. Adaptive and or acquired immunity is something you gain over a period of time. Okay, so in innate, the best examples are your blood. Your blood has white blood cells. Okay, WBC. There are different types of WBC. Sorry, is it not presentation mode? Okay. Is it now in presentation mode? Okay, so this I have explained how infection and malnourishment are interrelated. Prolonged infection will lead to malnourishment. Prolonged malnourishment will lead to infection, easy access to infections. Okay, so immunity, two types: innate, adaptive. You are born with innate immunity, you acquire adaptive immunity over a period of time. That is the key difference. So innate immunity, there is humoral. Here also you have humoral. Don't confuse that, because here the humoral means when you are born. Okay, there are B lymphocytes which are made in your liver and it is stored in the bone marrow. That is why we have a humoral immunity under innate section. Okay, it gets activates. It is activated when antibodies are formed. That happens after birth. Okay, so yeah, cellular immunity, macrophages, granulocytes, basophils, mast cells, dendritic cells. Okay, these kind of cells are found in the like dendritic cells are found in the central nervous system. Basophils, granulocytes, macrophages are like the different forms of WBC. Okay, white blood cells. White blood cells have 5 different types: neutrophils, basophils, eosinophils, etc. So those everything come under the cellular immunity. In adaptive immunity, we'll see that here. Adaptive or acquired immunity, both are the same. Immunity that develops during your lifetime. Even under that, you have active immunity and passive immunity. Okay, active immunity develops in response to infection or vaccination. For example, natural chicken pox. Okay, if you have got chicken pox in your childhood, you will not, most certainly you will not get the second infection with chickenpox, because your body already knows the virus, knows the bacteria, and it will completely eradicate it when it comes in contact with that again. So because antibodies have already been developed to treat that specific infection. Okay, you have got chickenpox doesn't mean you will be saved from measles or mumps, etc. For that you will for that you have to get those first, and then only you will get the memory immunity for that. Okay, so that is natural. Artificial means you have got polio vaccination in your childhood, PCG vaccination in the childhood. Okay, through vaccinations you develop antibodies, and these antibodies will protect you throughout your life. So that is natural and artificial active immunity. Once you get infection or at least vaccination, your active immunity will start. Okay, it will remember the response which has to be again followed up when in case you get these infections in the future. Okay, so you are safe with active immunity. Passive immunity, by the name itself, it is passed on to you. Okay, how it is passed on to you? Through the mother's breast milk. Okay, when a newborn child doesn't have acquired immunity, the only immunity the child gets is through the immunoglobulins from the mother's breast milk. So the natural is antibodies received from the mother through breast milk. The second is artificial, the immunoglobulins which are injected into you. Okay, there are certain the vaccinations are of two types. Okay, one kind will have the live attenuated viruses. Okay, either it is live or it is half dead or dead virus. The other kind of injections are there which doesn't have virus or anything, but it has the antibodies which will take care of that virus or that infection. So that is immunoglobulin injection. Okay, because when earlier when coronavirus pandemic was going on, the government was calling up for people who have recovered from corona to give their plasma for research and to make injections and all. Okay, so that is the artificial kind of passive immunity. Somebody's someone else's immunoglobulin is put into you, they have passed on their immunoglobulin to you. That is passive immunity. Understood the difference between these two, active and passive? Active, your body has to make. Okay, your body has to make the antibodies only when the infection happens or you get vaccinated. Only then the body can make antibodies, either through natural ways or artificial ways. In passive, it is passed on to you. Somebody else's immunoglobulins are passed on to you, somebody else's antibodies are passed on to you. That is passive immunity. Nutritionally relevant infections and infestations. Okay, so some bacterial infections like tuberculosis, whooping cough, diarrhea, enteric fever, rheumatoid arthritis, pneumonia, tonsillitis. Okay, these are some kind of bacterial infections that will either lead to malnourishment in a long run. If it is not treated properly, it will lead to malnourishment. For example, somebody who is suffering from tuberculosis, if you have noticed that if somebody is suffering from tuberculosis from a very long time, there will be an excessive muscle wasting in their body. Remember the child from previous topic, Marasmus, the child who has Marasmus. Okay, how will the child's body look like? The entire skeletal structure is visible. Okay, so the same thing you will see in somebody who is having tuberculosis for a very long time. That is how these bacterial infections will affect the nutrition. Okay, the same viral infections like measles, common cold, influenza, pneumonia, okay, diarrhea, chickenpox and all. So these things also, when somebody is in a prolonged state in these kind of infections, it will lead to impaired nutritional status. Okay, parasitic infection, very common in children, because like playing in the mud and eating mud, etc., and sharing food, not washing hands before food, etc. So these are the very small reasons through which the child may be prone to getting parasitic infections. Okay, so hookworm infections, tapeworm infections. Okay, that will come under this thing. So if a child is having a parasitic infection in the intestine, like hookworm or tapeworm, there is excessive blood loss, or the nutrition what the child is having is completely taken by the parasite and depriving the child's body from nutrition. Okay, so that is how parasitic infections will alter the nutritional status. Effect of malnutrition on infection. Once a child is once not just a child, even an adult who is in a malnutrition stage, okay, how easy it is for them to acquire infection. So severe acute malnutrition, very easy. All the immunological functions to different degrees, lymphocytes, T lymphocytes, B lymphocytes, antibodies, everything will come down when a child is suffering from severe acute malnutrition. If you remember the treatment phase, okay, in the initial phase itself, after taking control over the life-threatening conditions like hypoglycemia, hypothermia, dehydration. Next, the doctors will focus on treating the infection. Why? Because when a child is in a severe acute malnutrition stage, he or she is very easily prone to getting any kind of infection. Their barrier, their immune response, everything is reduced. Vitamin A deficiency. Here, when both specific and non-specific protective mechanisms are impaired, your immunity's specific mechanism is like you have antibodies specific to chickenpox, you have antibodies specific to polio. Okay, non-specific is like you have something, you had something, or you acquired something which is releasing toxins in the body. Okay, that is not toxins are not organic, it is they're kind of inorganic. Okay, so these toxins don't require specific antibodies to tackle them. Okay, non-specific antibodies can go do the phagocytosis and everything, and release the toxins out of the body. Okay, so that is non-specific. Specific is for that particular infection, a particular antibody is there in the body. So vitamin A deficiency will reduce both these responses, specific as well as non-specific will be reduced. And also the main thing is there are helper T cells. Okay, when it comes to immunity, the acquired ones, there are T lymphocytes, B lymphocytes, etc. Okay, the T lymphocytes are produced by the thymus gland. B lymphocytes are produced by the liver when when in the fetal life, and after birth these will be stored in the bone marrow. That is why we call it B lymphocytes, because it is stored in the bone marrow. T lymphocytes from the thymus gland. Okay, so these T lymphocytes require certain cells called as helper T cells for its secretions, for its immune response and everything. So vitamin A, specifically retinol and all. So vitamin A is known to be a component of hyper T cells, and it will help the T lymphocytes to do its function. If vitamin A deficiency is there, there are reduced helper T cells, and thus the T lymphocytes function will also be impaired. That is why vitamin A is very important when it comes to immunity. Yeah, for T lymphocytes and B lymphocytes, please refer to the page number 462. Okay, just read through that. If you didn't get that, please let me know. Okay, T lymphocytes, remember T lymphocytes is made by the thymus gland. Okay, thymus gland. It is there in the throat area. Okay, near the thyroid gland. So that is thymus gland. It in the childhood you require thymus gland because T lymphocytes are made, but during the adulthood the thymus gland decreases in size. It undergoes atrophy and all. It decreases in size, and there is no much function after adulthood. So yeah, and in B lymphocytes, it is made in the fetal liver. When you are in a fetal stage in the mother's womb, the liver makes B lymphocytes. But it is stored in the bone marrow. Okay, so B for bone marrow, B for B lymphocytes, T for thymus gland, T for T lymphocytes. Okay, both of these T lymphocytes and B lymphocytes, they are stored in the lymph nodes along with the cardiovascular system. Okay, blood circulatory system, cardiovascular system, you have another circulatory system in the body, that is called the lymphatic system. Lymphatic system has lymph vessels, lymph nodes and everything. So lymph nodes is something, if you it is found in under your throat, under your underarms, groin area, inguinal area, etc. Okay, so you if you go on infection anywhere, these lymph nodes will become big, enlarged, swollen. Okay, and they start releasing T lymphocytes and B lymphocytes to tackle the infection. Okay, so just go through that image. If you understand that, it's well and good. Otherwise, you can ask me later. Then you have vitamin D deficiency and vitamin C deficiency. See, when you are having vitamin D deficiency, you have rickets. Okay, deficiency of vitamin D causes rickets, and it is often seen that the children who have rickets, they have a very decreased immune response. So that is seen. So if at all the rickets is corrected, vitamin D deficiency is corrected, automatically their immune response will also increase. When it comes to vitamin C, vitamin C affects many immune system modulators like T lymphocytes, B cells, etc. Along with that, they enhance the neutrophils. Neutrophils are the kind of your white blood cells. Okay, in the chemotaxis and phagocytosis, vitamin C helps these cells. Iron deficiency. If you have iron deficiency, impaired lymphocyte is there, impaired neutrophil function is there, and also if you are getting a tetanus toxoid injection, TT injection, okay, and people with the low iron deficiency, okay, the response is very bad. Okay, taking tetanus toxoid will not help those who have iron deficiency. Okay, so that is why iron deficiency also has to be corrected if you have to correct your immunity. Zinc deficiency, the lymphoid tissues, which is present in the lymphatic system. Okay, it undergoes atrophy, it decreases in size if zinc is not present in adequate amount in your body. So that is how different vitamins and their deficiency will affect the infection. So effect of infection on nutritional status, you can take a screenshot of this slide, okay, because whatever is given in from page number 468 to 469, the effect of different carbohydrates, proteins, lipids and all, it is summarized in this one slide. If you read this slide, it is more than enough. Okay, so the first thing, the protein catabolism, when the proteins break down. Okay, if you are having any infection, if somebody is having infection, the way in which the protein has to be broken down, okay, and nitrogen balance should be maintained in the body. We have spoken about that in the previous class about protein. Okay, protein is the only component, only nutrient which has nitrogen attached to its chemical structure. No other micronutrient or macronutrient has nitrogen to its chemical structure. Okay, so to have a positive nitrogen balance and to have a good protein metabolism, you should be free of infection. If you have infection, protein undergoes catabolism, too much of breakdown, and everything will be excreted out of the body instead of being stored and utilized, and there is a negative nitrogen balance in the body. Okay, that will affect the enzyme secretion, etc. Then depletion of the carbohydrate stores and increased resting energy metabolism. Your liver stores excess glucose in form of glycogen and all. Okay, so that will be depleted. Okay, because when tomorrow when you require the energy from these stored glucose pockets, it will not be available because it was completely depleted during infection. Because during infection, you do not feel like having food. Okay, the body goes in the state of loss of appetite. When you have certain infection, nobody wants to have food. Automatically, what the body can do, it has to use up the stores of carbohydrates for energy. Okay, so that will and even if the infection is for a very long time, automatically the person may undergo severe weight loss, and the person may undergo a malnourishment stage. Increased gluconeogenesis, the liver is using up the carbohydrate stores, it uses gluconeogenesis cycle to make glucose out of the to make carbohydrates from the stored glucose. Peripheral insulin resistance, uh, even at the high when too much of glucose is again being secreted back into the system from the liver, okay, insulin will not work on it. Insulin will not be able to bring down the blood sugar level. Altered lipid metabolism, the breakdown of lipid will be altered. It will lead to free cholesterols roaming around in the blood vessels. Okay, it will be deposited here and there. It may also get deposited in the liver. Ferrous, the iron, copper, zinc redistribution is altered, because if you require absorption of certain minerals, this electrolyte balance should be apt for certain absorption of certain nutrients and minerals. So this redistribution from the intestine back into the tissues will make sure that your intestine is deficient of these minerals, and it will lead to malabsorption of other nutrients. They are called trace elements because they are not found in access in the body. Okay, you require very few amount of these elements in the body, especially when it comes to iron and all. When we were discussing in previous chapters, okay, if you are having 100 gram of iron, okay, if you are ingesting 100 gram of iron, only 3 to 5% of that is 3 to 5 gram of that iron will be absorbed. Rest everything will be excreted. So 3 to 5% of the ingested iron means it is very trace in amount. Okay, the same applies for copper and zinc. There is no food that which is abundant in zinc and copper. Trace amount of these minerals are found here and there. Okay, increased vitamin utilization and excretion. Whatever vitamin you are having, okay, the food whatever you are having, it has vitamins, certain amount of vitamins, okay, that will be completely utilized, and instead of being utilized by the cells, and instead of being stored for future use, it will be excreted. This all takes place if your body is in a state of infection. And if these things, the points which I have listed down here, if they occur for a very long time, automatically you can imagine what kind of nutritional status a person may have in the future. Okay, so that is how infection affects the nutritional status. Effect of nutrient infection on nutrients, specific nutrients, how it is affecting protein. The serum albumin will be decreasing. And why it is decreasing? Because when you are in a state of infection, when you do a urine analysis, you will find trace amount of protein. The serum albumin means the protein which should albumin should be present in the serum, okay, the blood serum. It is getting excreted through the urine. Okay, so that is how the protein, the serum albumin level will not be maintained, and you require protein in the blood so that all the macronutrients don't just go here and there, just out of the blood vessels. The protein acts as a buffer. It will keep the things where it is supposed to be. Vitamin A. Intestinal absorption of vitamin A will be impaired. Your intestine will not be able to absorb enough amount of vitamin A. B vitamins, all the B complex vitamins. Thiamine is one of the B complex vitamins. When you have infection, the thiamine metabolism will be affected. Also, there are high chance that the person may suffer from beriberi. Beriberi is the deficiency, one of the deficiencies of vitamin B. Okay. Ascorbic acid, that vitamin C. Children with malaria have seen a marked decrease in the blood concentration of vitamin C. Even if they're having enough vitamin C, if you are suffering from malaria, the blood concentration of vitamin C decreases. Okay, and it is shown that there is a low level of vitamin C when the blood test was done in a school children after there was an outbreak of influenza. Okay, for example, even now when the pandemic is going on, those who are affected with coronavirus, if you check their vitamin C status from the blood analysis, it will be very low. That is why one of the reasons why they say to take vitamin C supplements to if when you are undergoing corona. Okay, it is not shown to prevent acquiring corona diseases. Okay, but once you are affected with this virus, it is better to have vitamin C supplements because the vitamin C concentration goes down in your blood. Okay, that there has been no studies which has proven so far. No studies have proven that taking so and so vitamins will reduce your will put you in a low risk group of acquiring corona. Okay, there has no studies done so far, but there are certain supplements which you have to absolutely take once you are infected. Vitamin D, if you acquire pneumonia, the pneumonia infection of pneumonia, that may aggravate rickets. If a child is suffering from rickets already and the child gets pneumonia, the child may go into a very complicated stage. Iron, hookworm diseases, etc., and malaria, especially chronic malaria, often results in iron deficiency. In hookworm disease, there is intestinal bleeding. Okay, these worm infestations, tapeworm infestations, they stuck into the intestine. They will drain out the excess blood for nutrients. Okay, and sometimes it will lead to intestinal bleeding, etc. So yeah, intestinal worms, they feed on the blood because in intestine the blood is rich in nutrients which it has recently absorbed, and when the worms stick onto the intestinal lining, they feed on the blood from within to capture all the nutrients, and thus depriving the body, the host body will be deprived from nutrient. Different types of worms have different mechanisms of using up the nutrients. That has to be kept in mind. Other minerals, for example, if you are having diarrhea for a very long time, okay, watery diarrhea for a very long time, a lot of your minerals will be lost. Potassium, calcium, magnesium, sodium, these will be lost because of excessive diarrhea, and thus there will be a state of electrolyte imbalance in the body. Then lipids, influenza, pneumonia, this can result in increased liver and fecal fat. Lipids means fat which is broken down. Okay, if somebody is suffering from influenza, pneumonia, etc., either through the feces, excess fat will pass out, or these free fat will be deposited on the liver tissues, leading to fatty liver. Carbohydrates, infections, when somebody is undergoing infection, the enzymes that are required to digest the carbohydrates in the stomach and intestine, those enzymes will not be secreted, or there will be a reduced secretion in those enzymes. Thus there will be malabsorption of glucose in the intestine because carbohydrates are not adequately broken down for absorption. Okay, growth and development, we have discussed that in the previous class of Marasmus and kwashiorkor, how growth and development will be impaired if a child is in a state of infection for a very long time. All the malnourished kids have either mental or physical growth stagnation at some point of their childhood milestone age. Malnutrition, there is a high mortality from measles in developing country because in most of the developing countries 40 to 60% of the kids are malnourished. On top of that, if the child is acquiring measles, okay, the mortality rate increases. The vicious cycle is the cycle which I have discussed earlier. Okay, the first slide, if you remember, about infection, malnutrition, and how infection and malnutrition is interrelated. Both will lead to each other when it is going on for a very long time. That is the vicious cycle. Nutritional problems in HIV patient. So when it comes to micronutrient deficiencies, especially vitamin A, zinc, iron, is adversely affected when a person is having HIV, because vitamin A is required for T lymphocyte synthesis and all. So the T lymphocytes are completely depleted. If you know how HIV works, okay, the HIV virus that will go and deplete the eat up all the T lymphocytes which you have already in the body. So if you do not have enough T lymphocytes, your body is prone to getting all sorts of infection. Okay, so that's the basic mechanism here. So um, on top of that, if a person is having deficiencies of vitamin A, zinc, and iron, it is much more difficult for the other lymphocytes to keep up with the upcoming infections. So iron is a very key component here. Okay, having iron supplements, zinc supplements, and vitamin A supplements. These supplements has to be given to the HIV patients. Macronutrients. When in the final stages of HIV, if you have seen a patient, or if you read about it, okay, in final stages of HIV, there is severe muscle wasting, okay, because the body cell mass is completely depleted because of the muscle, the fat which was stored in the body, the muscle mass which is there, the glucose which was stored in the muscle, okay, everything will be completely depleted. Okay, that will lead to severe weight loss. This happens in the later stages of AIDS. Okay, so that is how macronutrient deficiency will take place in HIV, because even if the body is getting adequate nutrient, uh, there is malabsorption seen, inadequate absorption seen, that and that nutrient will be excreted from the body. So in that case, the body has to use up the stores which is already present. So that is why you see such muscle wasting in HIV cases in the later stages. So just read through these paragraphs, okay? No need to mug up, but just understand how which micronutrient are important: vitamin A, iron, and zinc. In macronutrient deficiency, how the body cell mass is getting completely depleted and leading to weight loss. So coming to COVID-19, so mortality rate is high in elderly patients, and also people who already have some coexisting morbidities like heart disease, or people who are diabetic, hypertensive patients. Okay, in these cases, mortality rate because of COVID-19 is very high. uh, Asymptomatic patients, those who do not have cough cold but may have been infected with the virus, can also transmit the disease. So the only thing which can prevent it is safe hand hygiene practices, social distancing, cough etiquette, using of mask, handkerchief, or any tissues while coughing and all, covering the mouth while coughing. These are the protocols to prevent droplet transmission. So mask has to be used always when in out. And in India, the most common vaccine used is Covishield and Covaxin. It is given in the textbook. Just read through that. Also, the important thing is nutritional status appears to be a relevant factor influencing the outcome of patients with COVID-19. Means if you had a very deficient state of nutritional status in any of the nutrition, okay, your prognosis will be poor, considered poor. But a well-nourished individual with COVID, their prognosis means the way they respond to the treatment and come out of the disease condition. Okay, that is quite good. So having a good nutritional status is kind of helping you to recover from COVID. Also, in the next page, the last page, 476, it is mentioned. Uh, there has so far no nutrient has been shown to have any specific role in prevention and treatment of COVID. Remember that. So far, as of now, there are no nutrient like zinc, selenium, vitamin C, or anything that has proven to prevent or treat COVID. Okay, but supplementation is useful when once it is known that you are deficient, or once you are infected. Supplementation is useful because having this nutrient supplemented, it will elevate your nutritional status. If you have a good nutritional status, your prognosis will be good. That is the only reason why supplements are referred during COVID treatment. Okay, but it is not like that these supplements will prevent or treat COVID. So that myth has to be cleared out. Any doubts in this?